Hello, I am Jo Thompson. I'm a data person who currently works with Arden and GEM Commissioning Support Unit. I've been working with data within the NHS for close to 10 years now, and within the NHS for about 11 or 12 years. And I've got a lot of experience in helping clinicians, service leads, project managers to identify issues and also identify the best way to tackle problems and overcome them. So there's some dashboards which I've made recently, some on my own, some in collaboration with others, and I'd just like to take you through them. Obviously this is a recording from yesterday now, so it's a bit of a Doctor Who moment here. But anyway, so this dashboard we're looking at here is all about asthma. So NHS England identified issues with the overprescribing of or over-reliance of reliever medications for asthma patients. So as a collective with these guys here, we designed a dashboard with in mind these characters here. Obviously, there's no actual links to a community clinician being a dinosaur. I can't even remember how the Flintstones came about, but you'll notice as we go through this dashboard, some of these characters will appear at the top of the page because they're the people that we had in mind when we were designing this, the dashboard. So this is one of my, I like this dashboard because it frames a problem and it shows you how you can fix it. So I'm going to take you through. First page, if it works. Here we go, a little bit slow because we're recording. So first page is a little bit dry. It's just about QOF compliance. So we've got a list of surgeries here. We've got a percentage of the patients who are core 20 plus. We've got what their QOF scores were in the previous years and the breakdown of what the QOF score is for the most recent year. We have here a breakdown of the number of practices within each score band, and you can also see the number of underperforming GP practices for the last 2 years. What you can do quite easily is if you want to know who your underperforming ones are, you can just click on each of these score bands and it will show you straight away who your practices are that you might need to be having a few words with. But here it's quite good, this one, because although we've got 2 practices scoring really low, what we can see down here is for the previous 2 years, they've achieved 100% on their QOF. So perhaps it's not as bad as it looks. It might just be a recording issue, etc. So it's always good to have a look at your data and ask questions about it. One of the things we have taken great care of, which I could have mentioned sooner but didn't, is all the colour coding. So although this is RAG rated in terms of the scores, we have taken care to make sure that the colour schemes are colourblind friendly. So if there's anyone watching this who is colourblind, it'd be good to have your feedback on that, because although we've tested it through various filters, we couldn't find a colourblind person. So feedback's always great. I'd love to hear it. So once we're looking at our practices, we can identify who's who. We can then go on to medication reliance, which is what this dashboard is all about, the over-reliance on reliever medications. So we have a list of the GP practices. We've got the size of the asthma cohort, so how many practices registered, how many patients registered to the practice have asthma, how many are prescribed over 3 asthma medications per year, percentage of those, and the number and percentage who are prescribed over 3 reliever medications per year. So it's these 2 columns here that we're really interested in, because the higher the numbers, the more interventions we need to make for the patient's benefits. What we have over here is we have a chart where each dot represents a GP practice, and they're plotted so that we can see the number of patients with asthma against the number of patients who are reliant on reliever medication. The colour of the spots indicates the percentage of patients within the practice who are over-reliant on reliever medication. So the reddest one down here is this guy. And this is Butte House Medical Centre. So that we've designed the tooltips, the pop-ups, to tell us where the practice is, the percentage. So we've got 41.6% are over-reliant on reliever medication, which is a total of 32 patients. So we can hover over any of those and have a good look. So this one as well, you can see the deprivation breakdown is very different for this practice. So we've got 2 practices with very similar reliance on reliever medication, 40.9, but very low deprivation for these patients. And over here, very high deprivation, 41.6. What we've also built in is some filters. So if you are only interested in a particular PCN or life segment journey, you can look at those and find the practices you want to target. But over here, this one's got the highest Butte House Medical. So it starts to get interesting now because we can work out where can we find these patients and make the interventions. So this is telling us about our patients. So the asthma cohort here is broken down by the ethnicity. It's also broken down by the deprivation decile. And we can also see the patients on a map. So this is color coded. So, sorry, it's a bit time laggy at the moment. So the purple areas are the ones with the highest prevalence or highest reliance on reliever medication. So we can hover over those, over any segment, and see the deprivation breakdown and the number of patients within it. We can also see about long-term conditions. So this was something one of our clinicians who was assisting with this work, he pointed out that for a lot of conditions, they go hand in hand with other long-term conditions. So he asked for this to be added in, and he was quite struck by how few patients had additional long-term conditions. So we can see we've got 35.2% had one or more long-term condition, and only 6.6 had two or more long-term conditions. It's plotted on a graph here. So a graph is not a graph, it's a table. So you can see the number of additional long-term conditions and the deprivation index across the top. And if you hover over, you can see where these patients are registered. So if you're interested in any particular segment, you can just hover over and find your patients. So what we can identify very easily from the map is the areas that require the highest interventions or where you can make the biggest difference. So we all know that services are strapped and we need to be targeting for the most effective way. So what we can do is we can click on our purple areas here, Luton, and this one here, wasn't it? Where we can straight away see some information about our patients here. So we can straight away see that we have a high number of Pakistani and other Asian background patients here, and we also have high levels of deprivation. So we know that could be down to transport, it could be down to all kinds of things which will make up this deprivation index, but it makes you think about how can we interact with these patients differently? What are we doing or what are we not doing for these patients that we're perhaps doing for others? And how can we transfer that to patients with different needs? So do we need to be providing literature in different languages? Do we need to be setting up community clinics in different places which are more accessible? It just starts to give you some ideas about what you can do. Also, again, we did stick the filters in so that people can see for different items what they want to look at. So what was I thinking here? Yes, so you can hover over, just see different things and see where your patients are. So this is starting to think where you can target. After you've got your ideas of where you can target and what you need to target with, you can move along to the case finder. Let me just clear this for a moment so you can appreciate the magic. Hang on, there we go. So this is all our asthma patients, and we have a number of filters here. I have taken a few of the descriptors out. These are the age and the sex are populated, but it's getting a bit too identifiable for me, so I've taken those out just for sharing for this purpose. So what we can look at, we did identify that Butte practice had a very high prevalence of over-reliance. So if we can just search for Butte. These are all this is our asthma cohort. So we've got 76 patients within it. We can order any of these columns as well. So if we wanted to order by ethnicity, we can do that just by clicking on the column header. If we want to just target the ones who are over-reliant on relievers, we can do that and see all our yeses. We can also filter on our core 20 plus. Are those patients core 20 plus or not? The life or the Smith segment, which tells you about the health or the life stage that these patients are at. And once you've made your selections, you know who you're looking at, what the clinician can do instead of working off a screen, because the patient IDs, they enable the clinicians to look up the actual patient ID. So these are pseudonymized. So there's a tool, an online tool that only certain people can access that enables people to re-identify these patients and see who they are within practice. So obviously you don't want to be sat here doing that at screen. So what you can do is you can press the export data button, and that will just chuck the data into an Excel file for you, which you can save wherever you want. And you can look at those patients later and get all your re-identification done. What you can also do here, it just pops up where the areas are, where are these patients. So if you think, right, I'm a community clinician, I've got half a day on Friday, I need to do something that's really going to make a difference. Where do I want to be? And you can see easily where these patients are, and that's going to enable you to target your interventions easily. There's some extra bits that we put in here just to show the effects of asthma on the communities. So this is about, for our asthma cohort, the number of inpatient admissions that there have been. We're thinking up here, look, ICB Fred and PCN Barney, because they like to think about costs. So we've started to bring some costs in here. What are the costs of the admissions for these patients? How many admissions we've got and what the cost is. So the top graph is all inpatient admissions, regardless of the reason, for our asthma cohort. And the one at the bottom is respiratory related admissions for our asthma cohort. So you can see there's quite a few each month just within that one region. So perhaps there's some interventions that can be made to reduce those number of admissions, because it's not good for anybody, is it? That's what we want to target. The UEC attends is quite an interesting one. So we've got the deprivation breakdown by cost and the average cost per person. And you can see on the chart the number. Hang on, let me just take this filter off. Sorry. So here, this is, as before with the admissions, it was all admissions for the cohort. This is all urgent and emergency care attendances for the asthma cohort. But what we can do is we can filter it down to yes, and then it will filter out all those asthma patients who are attending with a broken arm or whatever else that was not breathing related. What we can see here, we can change the date as well, actually. So if you wanted to look at it at a longer time frame or shorter time frame, you can do. And what we can see here, which is pretty handy, is a patient list, which is telling us how many attendances these patients had within the time frames that you've selected. So you can straight away see that these patients you've got 3 attendances within this time frame for this patient for a breathing related issues. So perhaps their asthma review needs to be done, but it just gives you an idea of who you might need to be targeting within your communities and within your cohort. So that's the end of that dashboard. I'll just quickly take you through some other bits and bobs if I can find them, because I've got too many windows open at the minute. This is a nice one. I love a decision tree. Everybody loves a decision tree. So with this one, this is not related to asthma at all. This is related to mental health, particularly ED attendances for mental health. So for this one, you can see we've had 360,000 attendances over this time frame. What you can do, if we wanted to look at self-harm attendances, we can do that. There's a lot of data quality issues. There's a lot of blanks here, but we can see there was a lot of people that were attending with self-harm issues. And we can see straight away the most prevalent one is asthma. I'm still stuck in asthma presentation mode. Paracetamol overdose, sorry. So, and you can see the age breakdowns as well. And I think working with the mental health and the ED data, it's really quite hard hitting, because you can really see the prevalence of mental health in the younger population, and not just that, but the outcomes of the mental health in the younger population. And it's really needs addressing quite urgently, I would say. There's lots of really other good stuff in that dashboard, but we must press on. Right, this is a dashboard here, which I made in collaboration with someone else in my team. This is all about SPC charts, again within urgent care. People, particularly directors, loved this dashboard because it really enabled them to focus and hone in on the items that needed the most attention. So whereas before it was finding a problem, framing the problem and solving the problem, this is helping to direct people's attention to where the problems are, and also help to direct conversations and keep people on topic. So you can just see a summary of all your indicators, whether they're improving, concerning, or whether they're flip-flopping around. And for each of those indicators, we then have a further page, which has got SPC charts, which help to tell the story about what's going on behind the indicators. But that is my time up. I think I've overtalked, and I am very, very sorry. So I shall stop presenting now and leave you to enjoy the rest of the afternoon. Thank you.